Good evening, everyone. Consultants, seniors on the call, colleagues. I want to welcome you again, day 10 of our revision. Today, we have Dr. Victor Nedi Kenneth to present on the topic fetal and perinatal circulation. So, Dr. Kenneth, please, if you are ready, your audience are ready. Thank you.
Good evening, chiefs and colleagues. We will continue today's curriculum presentation, and my topic is fetal and perinatal circulation. Please, am I audible?
Yes, you are, please. Please, do you see the recording on your screens? I don't see it here on mine, so I just want to be sure.
It's recording. It's recording.
All right, thank you. Kindly go ahead.
Okay, we'll be discussing using the following outline. So by way of introduction, fetal circulation consists of system of blood vessels that's responsible for transportation of blood, nutrients, and other essentials between the placenta and the developing fetus. It's different from the adult circulation. One, in the presence of high vascular resistance in the lung, pulmonary circulation, as well as the fact that fetal circulation has low oxygen saturation and the presence of several shunts that we'll get to see later. It's important to remember that the placenta plays a major role in fetal circulation. So by way of refreshing ourselves on the embryology of placenta, it's a spongy disc-like structure. It's a temporary structure that will be removed or will be delivered during delivery of the baby as well. So it's a temporary structure. It's spongy-like, disc shape, measuring about 20 centimeter in diameter and 3 centimeter thick. So it begins, the development begins around the second week of gestation and is completed after 12 weeks. By 12 weeks, it becomes fully functional. So before implantation, this function is being the fetus takes derives nutrients from the uterine fluid. And then the point of implantation, the stromal cells takes up this function, then followed by the yolk sac. And then after 12 weeks, the placenta becomes fully functional and takes up the function of gaseous exchange, nutrients, oxygen supply to the fetus. You could recall that the placenta has the fetal part and the maternal part. The fetal part is contributed by the chorion. The chorion consists of the extraembryonic mesoderm and the trophoblast. So the trophoblast is what aids in implantation. It's further divided into the cytotrophoblast that actually gets the developing embryo attached to the uterine wall, and then the syncytial trophoblast, which is more superficial. The syncytial trophoblast now proliferates and then develops some cavity in between, known as the lacunae. They also erode the uterine capillary wall, and this capillary, the lacunae becomes subsequently filled with the capillary blood. With time, the inner part, which is the cytotrophoblast, extends into the syncytial trophoblast, projects like a finger-like projection, and that's the primary villi. Subsequently, the extraembryonic mesoderm extends into the primary villi, transforming it to the secondary villi. And when the blood vessel develops in it, it becomes the tertiary villi. These blood vessels now is connected to the uterine artery and uterine vein. Subsequently, we will see as we discuss further. So the species, okay, this is what I was trying to talk about. This is the cross-section of the placenta. This is first the primary villi when it's just the cytotrophoblast. When the extraembryonic mesoderm extends into this part, it becomes secondary, and with the presence of blood vessels in it, makes it a tertiary villi. Then the intervillous space is where exchanges occur. Then this is the maternal side, contributed by the decidua versalis, the maternal blood vessel in the maternal wall. So this is where gaseous exchange, nutrients is reabsorbed, and then taken up by the uterine vein to the fetus. So the umbilical cord too, the cylindrical structure measuring about 50 to 60 centimeter in length, also a temporary structure that houses the umbilical vein and the umbilical artery. The function of the placenta includes that of respiration. The fetal blood, the umbilical artery takes back deoxygenated blood to the placenta, which is exchanged with the oxygen from the maternal blood, nutrients as well. It also excretes creatinine, urea, and other waste. Its endocrine function is that of production of human chorionic gonadotropin hormone that is used as a test for it's what is employed in pregnancy tests. It also produces progesterone and estrogen for smooth wall as well. It's also pretty mother to the fetus. So we've talked about this. The umbilical cord begins to develop around the third week and becomes fully developed at seventh week. Its contribution is from the vitelline duct, the body stalk, and the allantois. Then it's the one that houses the umbilical arteries and veins. So if it is shorter, it can prevent fetal descent at labor. If it is too long, it can loop around the baby's neck and cause fetal distress or umbilical prolapse. So the fetal circulation proper, we are following the umbilical vein now from the placenta. It carries oxygenated blood to the fetus. The blood in the uterine vein is about 80% saturated. So about 30% of this blood carried by the uterine vein is shunted through the ductus venosus. Okay, before this we get there, the umbilical vein usually gives off a small branch, the left hepatic vein that supplies the left lobe of the liver. And then before dividing into the ductus venosus and the portal sinus, some textbook called it arcuate vein. Or yes. So the ductus venosus carries oxygenated blood and bypasses the liver, while the portal sinus drains into the portal vein that supplies the right lobe of the liver. And then also the veins that also join the abdomen and lower extremities joins with the right hepatic vein. When the portal vein becomes the right hepatic vein, and then drain into the inferior vena cava. So that means blood from the ductus venosus and those that drain the liver, the abdomen, and the lower extremity also empties into the inferior vena cava. But there is minimal mixing of this blood in the inferior vena cava. This is as a result of differences in the flow velocity between that from the ductus venosus and those ones that drain the deoxygenated blood joining the abdomen and the lower extremities. So the blood in the ductus venosus has a higher velocity than that and is more oriented to the medial part. It's described as medial and posterior part of the inferior vena cava, whereas the deoxygenated blood is more aligned to the lateral and anterior parts of the inferior vena cava. So this blood now moves to the right atrium. At the entrance of the right atrium is a eustachian valve. that directs the velocity of the blood from the ductus venosus towards the foramen ovale, whereas the other deoxygenated blood is directed towards the right atrium proper and then into the right ventricle, such that the blood that is now in the left atrium is that with high oxygen concentration saturation coming from the umbilical vein through the ductus venosus and then to the left atrium. It's about 65% saturated when compared to the 55% that is found in the right atrium. So the blood in the left atrium is more saturated with oxygen than that in the right atrium.
Okay.
So the right atrium also receives venous return from the that drains the head and neck and upper extremities through the superior vena cava, as well as those that are from the lower extremities from the inferior vena cava. From here, this blood moves then to the right ventricle. From the right ventricle, the blood moves into the pulmonary artery. And in this pulmonary artery, about 90% of this blood is shunted through the ductus arteriosus into the descending aorta, usually distal to the origin of the left subclavian vein. And then just 10% goes to the lungs. This is needed for proper development of the lungs. So the blood now that supplies, that is found in the descending aorta is to supply the lower extremities, the abdomen, whereas the one that is more saturated, that is found in the left atrium, it's meant to supply the heart, the brain, the organs that need more oxygenation. Now, the blood in the descending aorta moves to the internal iliac artery, which joins with the umbilical artery. At this point now, they are about 40% saturated. It's now taken up by the umbilical artery back to the placenta for oxygenation. So this is what I've been trying to explain. We have a single umbilical vein and a pair of umbilical artery. So the umbilical vein at this point gives up the left hepatic vein and then divides into the ductus venosus and the portal sinus that drains the liver. Then the blood from the abdomen, lower extremities, and all gets into the inferior vena cava alongside the ductus venosus. There's minimal mixing. This one is aligned more medially and posteriorly, while this is aligned more laterally and anteriorly, directed by the eustachian valve towards the foramen ovale and then to the left atrium, whereas venous return from the superior vena cava and the lower and the inferior, the deoxygenated blood from the inferior vena cava is directed towards the right ventricle, then to the pulmonary artery, and then through the ductus arteriosus, distal to the origin of the left subclavian artery, supply the lower extremities, and then back to the internal iliac arteries. This is the the umbilical arteries taking the oxygenated blood back again to the placenta for oxygenation. So noted that the distribution of the fetal cardiac output when observing magnetic resonance imaging and Doppler showed that placenta receives about 45% of the cardiac output. The brain receives about 25 to 30%. The abdominal organ receives 20 to 25%, then the lungs receive about 8 to 10, the heart receives at least 3 to 5% of cardiac output, respectively. I forgot to mention that there is a valve also at the ductus venosus. Then it's physiological, helps to limit the flow to the fetal heart during periods of increased cardiac output, especially when there is uterine contraction. So blood flow to the fetus is limited by those physiologic sphincter in the ductus venosus. So we recall that at this time the hemoglobin in the fetus is hemoglobin F, the fetal hemoglobin, characterized by its high affinity for oxygen. This helps the fetus um, um, to be able to cope with this low oxygen level because they have high affinity and not really readily it's not readily displaced. As well, its oxygen dissociation curve is shifted more to the left. So the fetus can also cope with this low oxygenation because most of the organs are not fully functional yet, like those responsible for maintaining thermal regulation. So thermal regulation of the fetus is being regulated by the mother, and their gastrointestinal tract is still non-functional because they directly absorb nutrients. So with this limitation in metabolic activity, they need less oxygen so they can cope with low oxygen saturation in the blood, as well as the differential blood flow, such that those organs that need oxygen more, like the brain, the heart, the liver, is shunting towards of oxygenated blood to that direction, so they don't feel the impact of the low oxygen saturation. So for perinatal circulation now, a lot of physiologic changes have to occur for a smooth transition from the fetal circulation to the perinatal to extrauterine life. So these physiologic changes must occur if the child or the neonate is to adapt well outside the uterus. One, remember that the lungs are not fully functional, are not functional in the in utero. They are filled, the alveoli are filled with fluid. Usually during the fetal life, the epithelium lining the alveolar cavity has this chloride-driven fluid reabsorption. So the alveolar sac is very non-compliant and is filled with fluid. So with catecholamine surge during labor, there is increased reabsorption of sodium and water from the alveolar, as well as the increased oxygen tension once the baby takes its first breath, causes gene expression for production of epithelial sodium channels that will help reabsorption of sodium as well as water from the alveolar space. And then also, the initial breath will result in negative hydrostatic pressure. This will push fluid from the alveolar cavity into the interstitium, and subsequently they are drained by the vasculature and the lymphatic. It was initially thought that the squeezing of the thoracic cavity during labor contributed more, but recent studies have shown that the contribution is very minimal and is more of this catecholamine driven sodium and water reabsorption. So one of those changes is alveolar fluid clearance. Now, following alveolar fluid clearance, the lung is ready for expansion. Following an initial effective breath, um, they make the alveolar space expand, and with subsequent inspiration, the functional residual capacity is established. So following this stretch by the expanding lung, there is release of surfactant, surfactant, and surfactant helps to increase compliance and reduce the surface tension. Now, the alveolar fluid is cleared, the lung has expanded, ready for the circulatory changes. So for circulatory changes, one, the placenta, which we talked about earlier, that's a temporary structure, was what sustained the high pressure, in a way it contributed to the high pressure in the pulmonary circulation and the low pressure in the systemic circulation. It produces prostaglandin E2 that helps constriction of the ductus at birth. This high pressure resistance of the placenta of the pulmonary circulation is reduced, and the systemic resistance increases. The systemic blood pressure increases as well. With this and the lung expansion, pulmonary vascular resistance reduces as well as pulmonary artery pressure. So when there is reduction in pulmonary artery pressure, it favors reversal of the shunt. So blood flows more from the higher pressure systemic circulation through the ductus arteriosus back to the pulmonary artery. And then that means that the blood supply to the lung will be increased. With increase in blood supply to the lungs has expanded now. There is increased oxygenation. The increased oxygenation contributes to dilatation of the pulmonary vasculature and constriction of the ductus arteriosus. So with this constriction, it functionally closes. So there's also increased blood flow through the pulmonary artery, and this results in increased flow, flow to the pulmonary vein. So when there is increased blood flow through the pulmonary vein, that means there is also increased blood flowing to the left atrium, and then subsequently the pressure in the left atrium rises with increase in the left atrial pressure to the extent that it exceeds the right atrial pressure. It will cause the flaps in the foramen ovale to close, and then the septum, premium, and secundum opposes itself and closes functionally the foramen ovale. From this at this point, that's at birth, and maybe a few hours, then complete closure of the foramen ovale occurs at 1 to 2 years. So with the delivery of the placenta as well, there is reduction in blood flow through the ductus arteriosus, and this causes, together with presence of endothelin-1 and other bradykinin, causes constriction in the smooth muscles in the ductus venosus, and this also closes. So this extrauterine transition is not that easy for preterm baby one, because they have not fully developed the ability, they may not have fully developed the ability to take a good initial first breath that will cause the lung expansion, oxygenation, reduction in pulmonary artery pressure. So they may still have persistent elevated pulmonary artery pressure. Or in babies that have neurologic abnormalities, they will not be able to take that deep and effective initial first breath. Or babies that have mechanical obstruction in the airway, like maybe meconium or developmental abnormality, they may encounter difficulty transiting from a fetal to perinatal life as a result of mostly impairments in lung expansion and reduction of the pulmonary pressure. So this table just shows when the shunt closes hemodynamically or functionally and then anatomically. So for the ductus arteriosus, this happens, most books says between 10 to 15 hours, most says 10 to 96 hours after birth, and then anatomically closes like 2 to 3 weeks after birth. Then there remains known as ligamentum atherosclerosis. For the foramen oval, it closes several minutes after birth, and it takes 1 to 2 years for it to close anatomically and remains as fossa ovalis. For the ductus venosus, it takes several minutes to close, and complete closure takes about 3 to 7 days. Some books says up to 3 months, and then remains as ligamentum venosus. The umbilical arteries become the medial umbilical ligament, the distal part, whereas the proximal part become the superior vesical artery. The umbilical vein becomes ligamentum teres hepatis. So this diagram is showing the aorta, the great vessels, and the ductus arteriosus has now fibrosed and has become ligamentum arteriosum. Thank you for listening.
Thank you. Thank you. So at this point, we'll want to ask the presenter questions. If you have any question, kindly unmute and ask your question. You can also type your question in the chat box for it to be read. Please, are there questions for the presenter? And in the absence of that, or whilst we wait, with our consultants on the call, seniors on the call, please, any contributions, any clarifications, please? Can I be heard, please?
Yes.
Any contributions, questions? Okay. So in the absence of questions, contributions, or clarifications from both participants and consultants, we want to say a very big thank you to our presenter. Let's appreciate our presenter. Let's appreciate our presenter. Thank you very much for this presentation. We'll then continue with the MCQs. I will make Dr. Charles Okori the host now, then I go off so that I can convert this presentation. When I'll rejoin, then I will share the questions, the MCQs. We are doing the new set of questions.